Now let's continue our third session of GIT. So it is about the minimal bright red blood per rectum. Evaluation of the minimum bright red blood per rectum. So the algorithm states that minimum bright red blood per rectum. Firstly, if the age is 40 to 49 without red flags, then we perform the sigmoid colonoscopy, and anoscopy is also useful in older patients to visualize a palpable abnormality found on the physical exam. About sigmoidoscopy as an alternative to colonoscopy can be used. So, if the age is less than 40 without red flags, then we do the anoscopy. We check for in the there may be no source identified on the anoscopy, or maybe there are hemorrhoids, and if the hemorrhoids are found, no need of further evaluation. If there is no source that is identified, then we do for sigmoidoscopy or colonoscopy, because maybe the defect is deep inside. Then there is if the age is more than 50 and or if they are red flags, so then we go for colonoscopy. And here you can see that unless they had normal colonoscopy 2 to 3 years back, uh, we perform colonoscopy. I don't know what is meant by that, but unless they had normal colonoscopy 2 to 3 years back. Okay, so if they have normal colonoscopy 2 to 3 years back, so then we don't perform colonoscopy. Maybe it's like that. So clinical features associated with the increased risk of serious disease include blood mixed with stool, systemic symptoms like fever, weight loss, diarrhea, anemia, change in bowel habits, and abdominal pain. So the red flags include change in the bowel habits, abdominal pain, weight loss, iron deficiency anemia, family history of colon cancer. So in these cases we are supposed to do the colonoscopy. Usually due to hemorrhoids, the minimal bright red blood per rectum is usually due to hemorrhoids or fecal or rectal fissures, but can be due to the serious causes like proctitis or rectal ulcers, colorectal polyps, and cancer. Evaluation depends on the patient's presentation and risk factors. Anoscopy is also useful in older patients to visualize a palpable abnormality found on the physical examination. Then factitious disorder, it is due to laxative abuse, frequent watery and nocturnal diarrhea, like 10 to 12 bowel movements daily with abdominal cramps. Characteristic biopsy findings include dark brown discoloration of the colon with lymph nodes shining through pale patches, that is called as melanosis coli. So melanosis coli is a very hallmark finding of factitious disorder, factitious diarrhea, that is caused by the laxative overuse. So how does it look like? There will be dark brown discoloration of the colon with lymph nodes shining through as pale patches. So I guess they have shown a picture over here. This is melanosis coli, and I cannot see the shining lymph nodes, but this is the darkness you can see. So this is melanosis coli, especially in those using or abusing the anthraquinone containing laxatives, for example bisacodyl, generally develop in 4 months of laxative ingestion and disappear in the same time of discontinuation. Alternative way of diagnosis is histologic evidence of pigment in the macrophages of lamina propria if melanosis coli is not seen on gross inspection. So if on gross inspection you cannot see the melanosis coli, then you have to check for the pigment in the macrophages of the lamina propria. Like here you can see the pigmented macrophages in this picture. Like these are the pigmented macrophages over here. So these are also characteristic findings that we find in the cases of melanosis coli or laxative overuse. So moving forward, diarrhea. Diarrhea can be divided into 3 main categories: watery, fatty, and inflammatory. Watery diarrhea can be further broken down into osmotic, secretory, and functional diarrhea. The hallmarks of secretory diarrhea include larger daily stool volumes, more than 1 unit per day, and diarrhea that occurs even during sleep, fasting or sleep. So secretory diarrhea will occur during fasting or sleeping as well. Secretory diarrhea most commonly occurs when luminal ion channels are disrupted in the gastrointestinal tract, resulting in a state of active secretion. A helpful tool in distinguishing osmotic from the secretory diarrhea is the stool osmotic gap, which calculates the difference between the plasma osmolality, considered equivalent to the Maillard stool osmolality, and double the sum of sodium and potassium ions in the stool corresponding to the calculated stool osmolality. So stool osmotic gap is equal to plasma osmolality minus 2 into stool sodium plus stool potassium. In osmotic diarrhea, non-absorbed and unmeasured osmotically active agents are present in the gastrointestinal tract. These ions result in an elevated osmotic gap of more than 125 milliosmol per kg. By contrast, in secretory diarrhea, is due to the increased secretion of ions. Therefore, the difference between the plasma osmolality and measured fecal sodium and potassium is significantly reduced, which takes the serum stool osmotic gap down to less than 50 milliosmol per kg. So if we are having a high stool osmotic gap, it means we are having osmotic diarrhea, and if the gap is less than 50, it means that we are having secretory diarrhea. Common causes of secretory diarrhea include bacterial infections like Vibrio cholera, viral infections like rotavirus. Rotavirus is the most common cause of watery diarrhea in the children. Congenital disorders of iron transport like cystic fibrosis, early ileocolitis and post-surgical changes. Secretory diarrhea can occur after the bowel dissection or cholecystectomy when unabsorbed bile acids reach the colon and result in direct stimulation. They result in direct stimulation uh, of the luminal ion channels. In addition, resection of the ileocecal area reduces the ability of the intestines to actively absorb sodium ions against the electrochemical gradient. The traveler's diarrhea, a short course of ciprofloxacin, about 3 days, it is advised for the empiric treatment of traveler's diarrhea, most commonly caused by Escherichia coli, and the strain is called as E-tech. I don't know, I guess it is toxigenic E. coli, enterotoxigenic E. coli. So it is subdivided into two further types, like the ones which secrete the GMP and ones that secrete the AMP. So like cyclic AMP producing or cyclic GMP producing, but basically it is the E-tech that causes the traveler's diarrhea. And for those, the patients are supposed to take a prophylactic dose of ciprofloxacin for 3 days. No, it's not prophylactic. Ciprofloxacin for 3 days is advised as an empiric treatment of traveler's diarrhea. So a person who is having a history of travel should take ciprofloxacin for about 3 days. Giardiasis. Giardia duodenalis, sometimes noted as Giardia lamblia or Giardia intestinalis, is common in the rural areas and developing countries and has an incubation period of 1 to 2 weeks. It is most commonly transmitted by the contaminated water but can be foodborne or transmitted person to person via fecal oral route. Most patients are asymptomatic. However, a significant minority of those who do develop clinical illness may go on to develop chronic giardiasis characterized by malabsorption, weight loss, and persistent gastrointestinal distress. Typical feature of giardiasis include diarrhea acquired during the international travel, abdominal cramps, foul-smelling stools, bloating, and benign findings on the abdominal examination. The preferred confirmatory test for the giardiasis is a stool antigen assay, that is direct immunofluorescence or ELISA. Stool microscopy for the oocysts and trophozoites can also identify the organisms and is useful in the resource poor settings or if other parasitic organisms are suspected. Some facilities also offer a nucleic acid amplification assay. Metronidazole is preferred treatment for the giardiasis. Asymptomatic carriers do not usually need treatment. Then we are going to the diverticulum of the GIT. It is very important topic. Diverticulosis. Association with the chronic constipation. It is very important buzzword for diverticulosis. If there is an old man with a chronic history of constipation, always suspect diverticulosis. Constipation with decreased fiber intake and increased fat diet will increase the intraluminal pressure. That will cause diverticula. Conversely, that will cause the formation of diverticula. Conversely, altered motility in the diverticular disease will cause constipation, most common in sigmoid colon. So basically they go hand in hand. Constipation causes diverticulosis and then diverticulosis causes constipation, because in constipation there is increased intraluminal pressure causing the mucosa to be pushed out from the muscularis and causing the production of a diverticulum. Then those diverticula alter the motility of the GIT and they lead to constipation. So most common is sigmoid colon, but bleeding diverticula are usually on the right side. It is very important. The right sided diverticula usually bleed. Bleeding is usually painless and resolves spontaneously. Minority required endoscopic or surgical intervention. The most common site for diverticular formation is left colon, but the most common site for bleeding diverticula is right colon. Then increase fiber, for example fruits and vegetables, unclear risk of diverticular formation but decrease the risk of acute diverticular complications. Then the next thing is about increase the risk of diverticular complications, diverticular hemorrhage and diverticulitis. Risk of diverticular formation but decrease the risk of acute diverticular complications. Okay, so increased fiber intake is an unclear risk for diverticular formation but decreases the risk for acute diverticular complication. Increased risk of diverticular complication, diverticular hemorrhage and diverticulitis will lead to increased meat intake, aspirin, NSAID use, obesity and possible smoking. Alcohol will lead to increased diverticular formation but not increased risk for diverticular complications. Diverticular bleeding. Colonic diverticulosis results from the outpouching of the colon walls at the point of weakness where the vasa recta penetrates the circular muscle layer of the colon. As the mucosa and submucosa herniate through the muscular layer, the penetrating artery that predisposed the diverticula become increasingly exposed. The exposed artery is no longer protected by the muscular layer and the diverticular bleeding occurs as the artery is injured from the erosion or trauma to the muscular layer. The diverticular bleeding usually manifests as a painless hematochezia. However, the right-sided diverticular bleeding which is more common than the left-sided, may sometimes present with melena. Other why melena? Because it has to cover a longer distance in comparison to the left-sided diverticular bleeding. So that is why it can present with melena. Other symptoms sometimes include bloating and cramping due to the cathartic effect of the blood in the gastrointestinal tract. Because blood is osmotically active and it causes the fluid to be moved inside the lumen of the GIT of the intestine, so that leads to bloating and cramping. The bleeding is usually self-limited, but management involves fluid resuscitation and, if necessary, transfusion of the blood products. Patients should undergo colonoscopy for the cauterization of tamponade of the patients should undergo colonoscopy for cauterization or tamponade of visible bleeding vessels, although angiography with embolization is an alternate management strategy. Now, it is very important that patients who undergo colonoscopy for cauterization of tamponade of visible vessels, this is the treatment of choice for diverticular bleeding, but there are some cases in which we cannot identify the point of bleeding because the colon is so filled with blood that colonoscopy cannot identify that. Then we go for angiography, but the limitation of angiography is that angiography only finds if there is only find the point of leak if there is active bleeding going on. If the active bleeding is not currently going on at the time of angiography, it will not be useful to diagnose the diverticular bleeding. Surgical management should be considered for the patients who continue to bleed despite the endoscopic and angiographic management. And the surgical treatment is like the Hartmann's procedure, or maybe we perform the proctocolectomy with the ileal bag, anal anastomosis, something on those lines. Yep. Diverticular bleeding etiology: arterial erosion due to the chronic mucosal outcropping. Clinical presentation is painless hematochezia in patients aged more than 40. Bleeding often self-limited but can recur. Diagnosis is colonoscopy or tagged red blood cell scan. The treatment is intravenous volume replacement, endoscopic therapy or angiographic embolization. The colonic resection of the persistent bleeding. The colonic resection for the persistent bleeding can also be done. The next thing is acute diverticulitis. The clinical presentation is abdominal pain, usually lower left quadrant, fever, nausea and vomiting, and ileus or peritoneal irritation. So the clinical presentation also includes leukocytosis. The diagnosis is made by the abdominal CT, oral and intravenous contrast. Management is done by the bowel rest, antibiotics like ciprofloxacin and metronidazole. Complications include abscess, obstruction, fistula and perforation. Inflammation due to the microperforation of the diverticulum, characterized by uncomplicated 75% and complicated 25%. So, inflammation due to microperforation of the diverticulum, it is characterized by uncomplicated 75% and complicated 25%. So, like uncomplicated diverticular disease, uncomplicated diverticulitis is in stable patient. The most of the diverticulitis is uncomplicated, but it can get complicated at times. So, uncomplicated diverticulitis in stable patients can be managed in outpatient settings by the bowel rest, oral antibiotics and observation. Elderly, immunocompromised, high fever or significant leukocytosis or have significant comorbidities like hospitalization and IV antibiotics. Complicated, it is associated with the abscess, perforation, obstruction or fistula formation. What is an abscess? It is a fluid collection. If it is less than 3 cm, we give IV antibiotics and observation. Surgery for the patient with worsening symptoms. Fluid collection if more than 3 cm, then we do the CT guided percutaneous drainage. If symptoms not controlled by 5th day, surgical drainage and debridement can be done. Sigmoid resection reserved for the patient with the fistulas, perforation with peritonitis, obstruction or recurrent attacks of diverticulitis. 10 to 15% patients have urinary frequency, urgency, dysuria due to bladder irritation from the sigmoid colon and inflammation. So 10 to 15% patients have urinary frequency, urgency and dysuria due to bladder irritation from sigmoid colon inflammation. CT scan, inflammation in the pericolic fat, presence of diverticula, bowel wall thickening, soft tissue masses, formable phlegms, and pericolic fluid collection suggesting abscess. Upper right X-ray shows non-specific findings. Barium enema, sigmoidoscopy and colonoscopy contraindicated in the acute diverticulitis. So we cannot do these procedures when there is acute diverticulitis going on because there is a risk of perforation. Colonoscopy is performed after the resolution of acute diverticulitis to rule out the colorectal carcinoma. So here they are saying that abdominal CT, oral or intravenous contrast is best diagnostic test for diverticulitis. The abdominal CT is the best test, differentiating from other diseases like colon cancer, kidney, and infection. Okay, and infection. So the next point is about Zancus diverticulum. Zancus diverticulum, the clinical features include usually age more than equal to 60, more common in males, causes dysphagia, halitosis, regurgitation and aspiration, and variable neck mass. The diagnosis is made by barium esophagogram and esophageal manometry. Management is done by open endoscopic surgery, and cricopharyngeal myotomy can also be done. The next point is about other clinical features. Include oropharyngeal dysphagia associated with a neck mass, gurgling in the throat. Potential complications include tracheal compression, ulceration with the bleeding. Develop immediately above the upper esophageal sphincter with a posterior herniation between the fibers of cricopharyngeal muscle. Occurs due to the upper esophageal sphincter dysfunction and esophageal dysmotility. The colovesicular fistula. The clinical features of colovesical fistula: etiology, diverticular disease, sigmoid most common, Crohn disease, malignancy of the colon, bladder, and pelvic organs that lead to colovesicular fistula formation. The clinical presentation include pneumaturia, that means air in the urine, fecaluria, which means stool in the urine, and recurrent UTIs, urinary tract infection, that with a mixed flora. The diagnosis is done by the abdominal CT with oral or rectal, not intravenous contrast. Colonoscopy to exclude the colonic malignancy. The pneumaturia usually occurs at the end of urination as the gas collects at the top of the bladder. It is a very catchy point that pneumaturia will come at the end of the urination because the gas being lighter than water will start accumulating at the top of the bladder, and as you urinate, firstly the stream of urine will come and after that there will be air that will be coming out. So this is the characteristic of the pneumaturia. And abdominal CT with oral or rectal, non-intravenous contrast, not intravenous contrast. So we give oral or rectal contrast, not IV contrast, because it shows contrast in the bladder with thickened colonic and bladder walls. So the treatment is usually surgery after infection resolution. So in this picture you can see that there is air in the bladder. So here you can see the air in the bladder, and the contrast is also present in the bladder, and you can see the thickening in the bladder. I think it is, yes, seminal vesicle, rectum, and blah blah blah. So here you can see the fistula is present over here like this. This is rectum and pubis, and now let's go forward. Now let's talk about mesenteric ischemia. Acute mesenteric ischemia. What is the presentation of acute mesenteric ischemia? Rapid onset periumbilical pain, often severe, pain out of proportion to the examination findings. Hematochezia will be a late complication. Risk factor is atherosclerosis, acute or chronic, embolic source, thrombus and vegetations, and hypercoagulable disorders. The lab findings include leukocytosis, elevated amylase and phosphate levels, metabolic acidosis, and elevated lactate. The diagnosis is made with a CT, which is preferred, or MR angiography, and mesenteric angiography if diagnosis is unclear. So atherosclerosis is a risk factor because atrial fibrillation, cardiovascular aneurysm, shock, vasoconstriction, acute thrombosis due to the peripheral arterial disease, or low cardiac output states, all of these things can lead to the mesenteric ischemia formation. Elevated HB will also be a finding in the mesenteric ischemia because of hemoconcentration. And the diagnosis, metabolic acidosis because of elevated lactate and low bicarbonate will also be a lab finding. Most common in the elderly, may result in the cardiac embolus, atrial fibrillation, arterial thrombus, atherosclerosis, or other etiology as in shock or vasoconstriction. The periumbilical abdominal pain can be associated with the nausea, vomiting out of proportion to the pulmonary, out of proportion to the physical examination finding if prolonged, more focal abdominal tenderness due to the local inflammation, infarction, perforation, or peritonitis, or peritoneal signs, for example, guarding and rebound tenderness. CT will show focal or segmental bowel wall thickening, pneumatosis intestinalis, small bowel dilation, mesenteric straining, and mesenteric thrombi. Management: patient with evidence of bowel infarction undergo immediate operative evaluation. Otherwise, diagnosis can be confirmed radiologically by CT angiography. Treatment includes open embolectomy with vascular bypass or endovascular thrombolysis. In addition, patients should be started on broad spectrum antibiotics and, in the absence of active bleeding, anticoagulation to reduce the risk of clot expansion. So we have to differentiate the acute mesenteric ischemia with appendicitis. So they are saying that acute appendicitis is uncommon in elderly patients. First thing, if it occurs, the presentation is less acute. In addition, in the absence of perforation and significant hypotension, patients with appendicitis rarely develop metabolic acidosis. The next point is about the chronic mesenteric ischemia. The etiology of the chronic mesenteric ischemia is atherosclerosis, smoking, and dyslipidemia. The clinical features include crampy postprandial epigastric pain, food aversion, and weight loss. Diagnosis is made by signs of malnutrition, abdominal bruit, that is seen in about 50% of the patients. CT angiography is preferred, but Doppler ultrasonography may also be helpful. Management: risk reduction, for example, tobacco reduction, nutritional support, endovascular or open surgical revascularization. The clinical features may also complain of nausea. The clinical features of chronic mesenteric ischemia include nausea, early satiety and diarrhea. Pain starts within first hour of eating and resolves within next 2 hours. The pathophysiology of pain is most likely related to the shunting of blood away from the small intestine. Shunting of blood away from small intestine to meet the increased demand of the stomach. In patients with atherosclerosis, the celiac or superior mesenteric arteries may be narrowed and unable to dilate appropriately to maintain the adequate blood now to the intestines. I guess it is blood flow. Abdominal X-ray and CT may show calcified vessels. Diagnosis requires better calcification. Then we have ischemic colitis. The risk factor for ischemic colitis is age more than 60, chronic renal disease or hemodialysis, atherosclerotic vascular disease and procedures, and myocardial infarction. Clinical features include mild pain and tenderness, hematochezia, diarrhea, metabolic and lactic acidosis. The diagnosis is made with a CT scan, thickened bowel wall, double halo sign, pneumatosis coli, and edema will be seen. So double halo sign is a very characteristic finding in the ischemic colitis. The next thing is colonoscopy, mucosal pallor or cyanosis, petechial hemorrhage, hemorrhagic ulceration with a sharp transition from affected to unaffected mucosa. Management of the ischemic colitis can be done with the supportive care, IV fluids and bowel rest, IV antibiotics, colon dissection, bowel infarction, or the clinical deterioration. So here you can see that the pain of ischemic colitis is usually moderate and lateralizes to the affected site. Repair of an abdominal aortic aneurysm is a common precipitating event as the patients are often older and have extensive atherosclerotic vascular disease. Contributing factors may include loss of collateral circulation, manipulation of the vessels with surgical instruments, prolonged aortic clamping, and impaired blood flow through the inferior mesenteric artery. So here you can see that the clinical features of ischemic colitis include fever, nausea, and leukocytosis. Then diagnosis, what is pneumatosis coli? Okay, so on the CT scan with IV contrast is performed urgently to assess the immediate need for the surgery, that is extensive bowel damage, perforation, gangrene. If surgery is not needed, colonoscopy to confirm the diagnosis. Unless the patient has perforation or bowel gangrene, most cases are managed conservatively with IV fluids, bowel rest, and antibiotics. The next point is commonly involved sites of the ischemic colitis includes splenic flexure at watershed line between the territory of superior and inferior mesenteric artery, and rectosigmoid junction at the watershed between sigmoid artery and superior rectal artery. So this splenic flexure is also called as the Griffith point, and the rectosigmoid junction is also called as the Sudeck point. Retroperitoneal hematoma. Retroperitoneal hematoma causes back pain, hemodynamic instability, anemia, weakness, and dizziness. Patients on anticoagulation, normal or supra therapeutic INR, raises suspicion for the retroperitoneal hematoma. Perform abdominal CT. Isodense area in the retroperitoneum will be seen. The risk of bleeding while on warfarin therapy is greatest in the patient with the risk factors such as diabetes, age more than 60, hypertension, and alcoholism. Now let's talk about angiodysplasia. So in angiodysplasia, it occurs due to the dilated veins and arteriovenous malformations. Increased incidence after age 60, common in the right colon but can occur anywhere. More frequently diagnosed in the patient with the advanced renal disease, okay, and von Willebrand disease due to increased bleeding tendency. Aortic stenosis also increases the risk due to acquired von Willebrand deficiency, because aortic stenosis will do what? It will form disruption of the von Willebrand multimers as they traverse the turbulent valve space induced by the aortic stenosis. Has been reported to remit. So it has reported to the von Willebrand factor level has reported to remit after the valve replacement. The diagnosis is made with endoscopy but may not be diagnosed properly due to poor bowel prep or location behind a haustral fold. Treatment is done. Treatment, if asymptomatic, no treatment is required. Anemia or gross occult bleeding, endoscopic cautery is usually done. So we'll talk about colonic polyps in the next session. Until then, Allah Hafiz, fi amanillah, and take care.